Good morning. My name is Mike Geis. I'm a fiscal consultant. Been doing fiscal consulting in this area for over 35 years. Did a lot of work back in the day with the former Department of Mental Health at the state level. And then transitioned from there into doing work with more counties as well as the various associations that support the counties. And so over the course of those 35 years, I've gained quite a bit of understanding of the revenues that support our community behavioral health system. And so today, that's what we're going to cover. And so some of your learning objectives, first of all, to give you an overview, not just of MHSA, and I know this is an MHSA conference, but really to give you an overview of the entire source of revenues that go into funding services delivered in our behavioral health system here in California, which is very unique compared to other states. And so it's very different than the way other states do things. And then we're going to dive into a lot more detail on MHSA. Through the course of this, I'll go through some numbers with you, but also try to present the different revenue streams. So hopefully you have an understanding of what drives those revenue streams, and then also how they are subsequently allocated and get down to the county level, the local level. So starting off kind of an overview here. And you'll see this is throughout the course of this presentation that the majority of our community behavioral health funding is through these allocations to counties. And the allocations are really, they're from different revenue sources. And again, I'll cover each one. But they're really driven by what's going on in the economy and not necessarily the demand for services. And in fact, typically, when revenues are the highest, or I should say when revenues are the lowest, because the economy is going down, is often when the demand for behavioral health services is the highest. So it requires a lot of fiscal planning at the local level to ensure the sustainability of services. And then in terms of how the majority of funds are allocated to counties, they're generally driven by population, as well as historical expenditures. So at least that is somewhat tied with the county population to potentially the demand for services. As you'll see throughout the course of this presentation, the different funding streams have different obligations, rules, and reporting requirements. They're often treated very siloed at the state level, while the counties at the local level have to try to blend the funding in order to maximize the use of the funding in terms of delivering services. And as probably you're aware, CalAIM, behavioral health payment reform that is effective with services after July 1st, 2023, is going to dramatically change how our Medi-Cal behavioral health services are funded. I'm not going to go into that here today, but just know that it is a pretty big shift. We're shifting away from an expenditure-driven reimbursement approach for Medi-Cal to an intergovernmental transfer financing mechanism, as well as we're transferring from a cost settlement administratively burdensome approach to a prospectively determined fee-for-service payment structure. So just again, kind of giving you a high level, we're looking at around $10 billion in community behavioral health funding in the current year. And you can see the different sources there. I'm going to mainly focus on 1991 realignment, 2011 realignment, and then Mental Health Services Act. But you can also see then that Medi-Cal FFP, or Mental Health FFP, as well as SUD FFP, which is the Medi-Cal reimbursement is also a very large and integral part of funding our services. And then we have a little bit of state general fund monies, some federal block grants that also go into funding services. But again, we're going to mainly focus on the three non-federal funding sources here today. So I'll talk about 1991 realignment, which is often referred to as the Bronson-McCorkindale Act, 2011 realignment, and the Mental Health Services Act. And starting off with, actually, we're going to do a couple other things first. Give you an idea of the variability in these revenues. You can see how the two realignments generally are fairly consistent. We had a little bit of a blip between 1920 and 2021, mainly due to COVID and some tax policies that shifted the timing of payment of taxes. But what you'll really notice is the incredibly large variance and fluctuations in the Mental Health Services Act, which again make it very difficult at a local level to plan, and create sustainable programs. Again, I had talked about briefly, we've got flexibilities and restrictions within each of these different funding sources. To the extent that a county actually has general fund monies dedicated to behavioral health services, those are the most flexible revenues. But the problem is you're often competing with other local priorities for that funding. And so there really isn't, in many counties, there's not a lot of county general fund that goes into behavioral health services. The 1991 realignment funding source, in terms of the allocations, that's the most flexible funding source that comes down from the state. And so counties have a lot of flexibility with that. 2011 realignment is restricted to substance use disorder services and Medi-Cal, especially mental health services only. And it's not a fixed allocation per program or service, meaning counties do have flexibility on how much they want to use in SUD versus specialty mental health. And then again, it can be used for all specialty mental health services in addition to SUD and EPSDT. And so it's not restricted just to EPSDT on the mental health side. And then MHSA funds, which I'm sure a lot of you are aware, can only be used when no other resources are available. And so it's not intended to supplement or supplant existing revenues, but to expand and augment existing funding streams. Expenditures with MHSA funds can only be used consistent with an approved plan. So there always has to be a connection between an MHSA expenditure and the MHSA approved plan that's approved through the local community program planning process. And then unlike the two realignments, MHSA funds have a certain period of time that they need to be spent. Otherwise, they revert back to the state and are redistributed to other counties. And I'll cover some of that in more detail when we get to the MHSA stuff. So starting with the two realignments, and I'm going to kind of group these a little bit together in terms of some of the global aspects of those. They really, what happened was in both, and I should also point out, 1991 realignment and 2011 realignment, the 1991 and 2011 refer to the years in which they were implemented. And so if you go back to 1991 and you look also at 2011, both of those years were years in which there was a downtick in the economy. The state was not going to have sufficient state general fund monies to fund all the services that they needed to fund. And so they went ahead and instituted 1991 realignment and 2011 realignment. And so what they did, well, at a macro level, it changed the financing and administrative policy for Medi-Cal behavioral health obligations held by counties, to where previously, prior to 1991, everything that was used to fund Medi-Cal was delivered through state general fund allocations to counties. So this shifted that in 1991. And then 2011, same sort of thing, where EPSDT and some of the Medi-Cal managed care obligations that were funded with state general funds were then shifted to counties, and counties became responsible entirely for funding Medi-Cal behavioral health obligations with some slight modifications related to Proposition 30. When there are additional requirements placed on counties, then the state kicks in some money. And so again, these were formerly state general fund funded services, and the state realigned those, both the responsibility and the funding for those programs, to the counties. But then it also specified now in statute that the priority for these funding sources is the Medi-Cal specialty behavioral health system. And so Medi-Cal becomes the primary obligation for these funding sources. And then to the extent that other resources are available or additional funding is available, then counties can use the funding for those other behavioral health services. From a policy perspective, the goal again was to place responsibility, both programmatically and fiscally, where the services were being delivered, and that is at the county level, and then also to provide flexibility for counties to use the funds for community-based services, with the intent of trying to reduce high-cost restrictive placements and then place the clients appropriately. But one of the key challenges through all of this, and again, these are allocations that are again tied to the economy and not necessarily tied to Medi-Cal enrollment, behavioral health caseloads, or any sort of costs or market factors. And so it makes it, again, a real challenge at the local level when you're receiving these allocations that really had nothing to do with the demand for services. And you're trying to manage this requirement that you fund and provide all Medi-Cal specialty behavioral health services. So a couple of things that specific to each of the realignments. Again, the 91 realignment, what that realigned were all community-based mental health services, including those covered by Medi-Cal, state hospital services, as well as services provided in an institution for mental disease, IMD, which are psychiatric inpatient services, all residential mental health, and long-term nursing care facility care services, which by definition is an IMD if they have more than 16 beds. I should also point out, and I don't have it on this slide, that this is just focusing on the mental health share of 91 realignment. 91 realignment also encompassed realigning social services and public health services as well. I'm not going to cover social services or public health, but just to give you a sense, it's broader than just mental health. And then with 2011 realignment, they called it the public safety realignment because it included a large chunk that goes to law enforcement, as well as some funding that goes to social services, and then some funding that goes to behavioral health. For the behavioral health side, it funds our Medi-Cal Specialty Mental Health, our Medi-Cal Specialty Mental Health EPSDT program that was state general funded. It funds, and then it funds everything that was previously funded in the substance use disorder system of care that was previously funded with state general fund monies, and you can see the list there. And this is the largest funding source that is used to draw down Medi-Cal for SUD services. In terms of then the revenue structure, there really are three different revenue sources that fund 1991 realignment. And the largest of which is sales tax. The half-cent of the state sales tax goes into 1991 realignment, and that is by far the largest source of funding for 1991 realignment. There also is a share of the state vehicle license fees that goes to fund 1991 realignment, and these are the registration fees paid by individuals when they register their vehicles. And then there's 14 million set aside in state vehicle license fee collections, and that's a fixed amount in statute, 14 million, and that is funded with amounts, the fines and penalties for people who pay their vehicle registration fees late. And that's just a fixed amount at 14 million. There also, in most counties, is a small county maintenance of effort for the mental health 1991 realignment. It's 48 million statewide. So it's not, out of a $10.4 billion system, 48 million really is not a big chunk of money. And it doesn't apply to all counties. There are some very small counties that do not have a county maintenance of effort requirement. And so in terms of the actual revenues, you can kind of see them here, and you can see some of the forecasts going forward. There is a fixed amount that counties receive on a monthly basis that is written in statute, and that's the largest amount that's included in the base. And then there has also been, since the base was set, there's been some growth, and that growth has translated into a mental health sales tax base and a mental health vehicle license fee base. And so those amounts will grow based on any growth in the base. Then the next year, and I'll talk about this in a second and give you another slide, the next year base equals the prior year base plus the prior year growth. So it's always going up. And so you can see here, again, it's kind of get these four different distributions. And the last one on there was the mental health vehicle license fee collections, the 14 million, that's a fixed amount. But really where the growth occurs is a little bit in the sales tax and a little bit in the vehicle license fee base. And then once the base is hit, anything above that amount goes into a growth account and then is distributed after the fiscal year, and that is what is shown here as the sales tax growth and the vehicle license fee growth. And then there's also some additional funds that get put into 91 mental health realignment, and that comes actually from 2011 realignment, just to make it even more complex. And those are just one-time type of funding amounts. Those do not impact the base going forward, but they are consistently allocated to the counties. And so again, kind of looking at the picture and the forecast going forward, we're pretty flat this fiscal year compared to last year. And then really just slight growth, not huge growth, that's projected out into the future, based on an anticipated 2 to 4% growth in sales tax revenue. So in terms of how the funds are actually distributed, and I kind of touched on it a little bit on that last slide. So counties each have a base amount that is set. It's equal to the prior year base plus the prior year growth. And the initial base was set based on allocations back in pre-1991. So the amount of state general funds that a county received served as the initial base. And then we have this kind of this moving growth as there's been additional growth that has increased the base. But the distribution of growth is somewhat complex in that when there is growth in sales tax funding, that growth, the priority for that growth first goes to cover any increase in social services caseload costs. So counties submit a claim showing their increasing caseload costs. Any of the sales tax growth will fund that amount first, and then whatever is left over gets distributed out to the 3 different programs: mental health, social services, public health, and then down to the counties. If there is actually growth left over. And the growth amounts, the timing of the growth amounts is that they're generally not available in the year in which they're earned, because all this accounting and everything else generally takes place. And so it's not known until you're into the next year. October, November generally is when you would know your growth attributed to the prior year, and you actually get the cash. And so most counties, or a lot of counties, wouldn't budget that growth, even though it's earned in the prior year. They wouldn't budget it until they were into the next year, just because it's not known at the time that you're closing the books, and you may or may not actually have any growth. And then when there are decreases, and we did see some decreases, and we have seen some decreases in the past, those are applied proportionally. So basically, you just keep getting your distribution, but then it just didn't hit the base amount. So if there's a decline in sales tax and vehicle license fees, that's what occurs. And so again, it would be applied proportionally to all the counties. Then in terms of 2011 realignment, again, realigning what were previously state general funded services to the counties through a dedicated revenue stream. In this case, it's predominantly the sales tax. There is a little bit of motor vehicle license fees, but that is for specific law enforcement programs. So none of that goes to the behavioral health services. So the behavioral health, what you would want to know is that when you're seeing sales tax go up, that generally means that 2011 realignment and funding for behavioral health services will increase as well. The one thing that you may not know is that in the initial year, in fiscal year 11-12, this revenue source was not going to be sufficient to fully fund all the obligations that the state was realigning under 2011 realignment. And so for a one-time basis, the state modified the statute, the MHSA statute, and used approximately $860 million of MHSA funding to meet their state general fund obligations for EPSDT, managed care, and then at that point, the educationally related mental health services. So it was a one-time thing, and $860 million of MHSA funds was used for those services. So in terms of the revenue, again, this is driven by sales tax. It's the same sort of approach as 1991, where the next year's base equals the prior year base plus the prior year growth. So you've got this constantly what we call a rolling base, which makes it a lot easier to plan, especially when there is growth. And you can see here some of the projections. Again, given some of the slowing in the economy that we've seen, sales tax revenues, they're up for the year, but not as up as they had been previously. So we're seeing a little smaller growth. The forecast for long-term growth is more like a 2 to 4% year-over-year growth in the out years. And you can kind of see that reflected in the forecast of 2011 revenues for behavioral health. In terms of how 2011 then gets down to the counties, it was initially kind of, it was based on historical expenditures. Then it was based a little bit on beneficiaries. Finally, in fiscal year 16-17, the state and the county agreed to a more consistent approach that would have this rolling base concept, where it is, you know, the amount that you received in the prior year becomes your base for the next year, and then growth is distributed based on your actual historical, a combination of your actual historical Medi-Cal claims, as well as your risk, which is the Medi-Cal beneficiaries in your county, and that is adjusted based on the higher cost beneficiaries. So foster care and disabled Medi-Cal beneficiaries tend to use more behavioral health services than some of the other beneficiaries. So it's kind of a risk adjusted formula. And so this way, if a county wasn't spending or didn't have the resources to spend, they were at least getting compensated in growth funds based on their risk, and hopefully they would use that money to subsequently expand their services. So again, kind of the key thing with both realignments, they're generally funded with sales tax. So when you see increase in sales tax, that means generally you're going to see a little bit more money for behavioral health services. Then we can go to the Mental Health Services Act. And as you're probably aware, this is what created a 1% tax on the millionaires. It's not a lot of individuals, although it is expanding and growing. So because there aren't many individuals that pay the tax, it's highly volatile, and it's you know, basically subject to these individuals' decisions, you know, and whatever their behavior is in terms of, you know, selling a stock, you know, to realize a capital gain, or a house or whatever, you know, that ends up, those behaviors and those decisions end up ultimately driving what is earned by the tax. What you may not know is that in order, so if you think about it, how do you know that you've earned $1 million? Well, you would look at a tax return, but those happen after the fact. And so in order to get cash flow to the counties and into the Mental Health Services Fund, the Act itself specifies that 1.76% of all monthly personal income tax payments go into the State Mental Health Services Fund on a monthly basis. And then there's kind of a reconciliation 2 years down the line between the tax returns and what was transferred on a monthly basis. And these are called the annual adjustments. And they are, in fact, incredibly volatile. And so again, the annual adjustment, it reflects the difference between what was transferred on a monthly basis compared to what was actually earned through tax returns. And again, just to kind of give you some demographic type information on who generally pays this tax, 33, or roughly a third, comes from wages and salaries, a third from capital gains. So it's highly dependent on capital gains. And then 20% from partnerships and S corporations, with the balance from a bunch of miscellaneous income. So it's really dependent. And there are sections of the governor's budget that talk about the large capital gains. And so it's very dependent on what actually happens in those capital gains. And again, the annual adjustments, they lag by a couple years. So for example, the annual adjustment for the current fiscal year that we're in, that was based on fiscal year 2021, that would have been calculated from 2020 tax returns, which given that you can file an extension, those were filed by October 15th, 2021. Then the Franchise Tax Board actually calculates the amount earned by the MHSA tax and informs the legislature generally by the beginning of March. And then that amount gets deposited in July and then subsequently distributed to counties in August. So it's got this kind of lag period, which has pros and cons. When we see the economy starting to go into a slowdown, we may still be seeing increased revenue in the Mental Health Services Act fund due to this 2-year lag. So it sometimes can give counties and the state the ability to plan for a downturn. And so again, when we talk about these cash transfers and 1.76% of all monthly personal income tax payments, that includes, generally the withholds that occur on the majority of individuals that are paid a wage, through an employer. But it also includes estimated tax payments, as well as any sort of filing tax payments when people file their income tax. And so those amounts, it's not really a consistent month-to-month amount, as you can see by this chart. So it varies pretty significantly, being April being the largest month when you have both an estimated tax payment and a quarterly and the filing tax payments. So you tend to have these spikes. And so it makes it difficult for a county or even for the state to project when or project off of the revenues that will be received. The other thing that starts to play into this is that even though the amount earned, the $1 million on the 1% on millionaires, even though that doesn't necessarily change with a change in tax policy, the timing can change with any sort of modifications to tax policy. So the IRS delayed or provided tax relief for any taxes that were due between January and September of 2023 due to the storm damage in almost every county in California. They provided this relief to where it's basically saying that you don't have to pay estimated taxes, you don't have to file your taxes until October. And so trying to model that makes it very difficult. But in looking at what happened, we had something similar happen when COVID hit and delayed some of the tax filings. But by best I can tell is it's going to be somewhere around 500-600 million of revenue that would have been received in the current year will be pushed out into next fiscal year. So again, just a timing thing, the amount earned is still the same, but again, it's these variations that provide some challenges for counties, and you'll see it in the numbers when we get to those in a little bit. So that's the revenues into the fund. The way the act is written, there are 5 components that are part of the Mental Health Services Act: workforce education and training, capital facilities, technological needs, prevention and early intervention, community services and supports, and innovation. We often refer to the first 2, workforce education and training, and the capital facilities, technological needs, as kind of the infrastructure components, while the rest are more your ongoing services sort of components. It's important to note that prior to making distributions to counties, that the state can keep up to 5% for state administration. And then the balance is distributed based on what the fiscal year in which the deposits are posted to the State Mental Health Services Fund on a cash basis. So in other words, there's not an accrual amount distributed based on that annual adjustment. It's based on actual cash into the fund. And so again, there's welfare and institution codes prescribe that unexpended and unreserved funds on deposit in the state fund at the end of the month are then distributed by the 15th of the next month to the county. It's important to note that through the state budget process, the state gets an appropriation from the Mental Health Services Act for administration, and that amount is reserved out of the initial allocation. So basically out of July revenues. And so that is set aside initially. The individual county allocations, you can see here, and there's a information notice that describes the methodology, information notice 22052, but it's really driven by population. And there are some different factors. We say estimated need for services. Well, that really is the population in the county. The county gets one warrant or check from the state, and then the county is required to comply with California Code of Regulations Title IX, which states that 5% of the funding goes to innovative programs, 19% for prevention and early intervention, and 76% for community services and supports. And then the act also prescribes that each county is required to have a local mental health services fund, and that amount is required to be invested consistent with other county investments, and the interest earned is retained in the local mental health services fund. So again, keeping on the funding, prior to fiscal year 08-09, there were specific amounts dedicated for the infrastructure components. So for workforce education and training and capital facilities, technological needs, that went away in fiscal year 08-09. But now counties may dedicate 20% out of their total MHSA funding, but it comes out of CSS. They can use for workforce and capital facilities technological needs. And then counties also have the ability to use up to 5% of their revenue for the community planning process. And so for supporting the consumers, family members, stakeholders, and contractors through that very important local planning process. In terms of the county expenditures, again, I said that that all MHSA expenditures need to be consistent with the approved plan. So counties are required by statute to prepare a 3-year program and expenditure plan. They gain approval of that through the whole community program planning process. And then the expenditures need to be consistent with that approved plan. The statute specifies that MHSA funds cannot be used to supplant existing resources. And then counties are also required to prepare and submit an annual MHSA revenue and expenditure report, which is posted on the Department of Healthcare Services website. If you ever want to see, as well as the county is supposed to post it on their website for transparency. So in terms of revenues, you can see some of the forecasts here. The cash transfers, again, this is the 1.76% of all personal income tax payments on a cash basis. You can see a big decrease in the current year, while a subsequent large increase in 23-24 and next year. That is due to this shift of payments that would have been received this year for estimated tax payments and tax filing, shifting that into October of next year. So the actual cash won't be received until next year. The annual adjustment, again, is the truing up or the reconciliation of the cash transfers to what was actually earned by the tax. And you see this huge number here. I will tell you that the $789 million in 21-22 was the largest amount ever in history. But now we've received publication that there's going to be 2.3 billion. That is the actual amount earned based on the 2021 tax year. And so that's going to be a pretty significant increase in 23-24. You then see some of the projections going out. And so if you think back to 2021, the stock market was up huge. It was like up over 20%, 30% in 2021, which is probably largely attributable to what you see here. The projection is then a decline in those annual adjustments. And to be honest with you, these may even be overstated because we've seen a decline in the stock market. Housing prices have kind of come down a little bit. So I don't think you're going to see the same level of capital gains. And so these may actually even be overstated. So that's the money into the state mental health services fund. Then it's like how much is going to go down to the counties in terms of component funding. And so we often refer to the funds distributed to the counties. We call that component funding, and the components referring to community services and supports, prevention, early intervention, and innovation. So again, this would exclude, out of that revenue that I showed you, it would exclude any funds that are expended and reserved at the state level. It also excludes the debt service that is used to fund the No Place Like Home housing program. And that's $140 million per year. As you saw from that previous chart, we anticipate large fluctuations in the revenues into the fund, as well as actual distributions, because of that large capital gains spike in 2021, followed by probably a subsequent, for sure, lower annual adjustments. And in fact, even the ones I showed you may be higher than anticipated. And just as a qualifier, there are funds that revert, as I talked about earlier. None of the funding that you see here would reflect that, because those revenues have already been distributed and they're just being redistributed. So in terms of actual component funding, you can kind of see here what the projections are. And again, you know, a bunch of the shift from 22-23 to 23-24 is due to the change in tax policy. And then also the large amount in 23-24 is kind of that abnormal annual adjustment that ties back to the 2021 tax year. And then it kind of comes back down to a more realistic level, which again, I think some of these may even be a little bit high in the out years. And if you really look at this, if you averaged, you know, 22-23 and 23-24, it ends up being around 3.6 million a year. So it's kind of like a slight increase, and then we're going to come back down to a little bit lower level. So that's kind of the projections. But I will tell you, the further out you go, you know, the more subject you are to any sort of changes in the economy, and you know, it to a large extent could be significantly off, which makes it very difficult to plan. Which initially was the intent of having a prudent reserve so that counties could prepare for some of these large fluctuations. And so there is a prudent reserve, and it's required in statute. And there's a couple of different sections of statute that talks about why, you know, that a county is required to establish one, and then that they can use funds from that prudent reserve in certain situations. The state has subsequently posted regulations that clarify the standards that must be met for a county to be able to use the reserves. And so again, that's getting a little clearer. There's been some additions to the act since the initial act, placing limits. 33% of the average CSS revenue received in the preceding 5 year is the maximum that a county can have in the prudent reserve. As I talked about previously, the amount that can get transferred in is based on total revenue. Their counties are required to assess the prudent reserve every 5 years. Again, that's part of what was added to the statute. And then in regulation, there's also a required minimum amount of prudent reserve equal to 5% of CSS revenue. And then lastly, just talk real briefly about reversion. Like I said earlier, MHSA funds have a certain time frame in which they must be spent, or they get sent back to the state and then redistributed to all the other counties. CSS and PEI in everybody except for counties with a population of less than 200,000, those must be spent within 3 years. Innovation's a little different because you have to get approval of an innovation project through the Oversight and Accountability Commission. The county has 3 years to get approval of the project. And then once they have approval of the project, they've got to spend the funds within the life of the project. The infrastructure components, because often those are larger projects, those have a longer lifespan, so that counties have 10 years to spend those. Funds in the prudent reserve are not subject to reversion. And then lastly, there was a provision for small counties to give them more than just the 3 years. They basically have 5 years to expend CSS and PEI or to get innovation funds into an approved innovation project. So that's quite a bit. We'll go ahead and open it up for Q&A here in the last 13 minutes that we have. So I'd be glad to entertain any questions on basically anything related to community behavioral health funding.
So Ted says, is there an up-to-date public record of how much money is left unspent from each of these funding sources for each county?
So no, there is not. There is on the Oversight and Accountability's Oversight and Accountability Commission's website, there's the fiscal transparency tool, which will show how much MHSA funding is unspent, I believe, in each county, but there is no reporting of 2011 realignment or 1991 realignment to show what sort of fund balances counties are maintaining. But I'll also say there's legislation proposed to change that.
Felix says, wouldn't the ARERs for each county shows unspent amounts?
No, because there's no revenue reported on the ARERs. It's just expenditures and transfers to the JPA. The initial, way back when, ARERs did show those amounts, but again, not for 2011 and not for 1991 realignment. But now your source is basically the fiscal transparency tool, where the Oversight and Accountability Commission takes the distributions that are distributed and posted on the State Controller's Office website and combines that with the revenue and expenditure reports submitted by the counties to show how much MHSA is unspent in each county.
Fabrico says, how confident are we with the FY23 amount of 1,882.1 million?
We'll find out soon. It's highly dependent on whether individuals, meaning everybody who files a tax return in the state of California and everybody who pays estimated taxes in the state of California, takes advantage of the tax relief to where you do not have to pay those taxes until October of 2023. If the majority of people continue to pay estimated taxes and continue to file, then that amount will be higher. But given what we saw in January, when this was first implemented, and we saw a significant decline in the amount of cash transfers, I think it's going to be around that amount. And I should also point out the revenue projections that you see here are consistent with the time period used by the state controller's office. So these are funds distributed, in August through, it's an August through July fiscal year at the county level. Based on funds just deposited in the state mental health services fund on a fiscal year, but it's somewhat of a guess. I know that amount looks low, especially given where we are. And the more recent distribution, or the more recent amount that just came in that you should be receiving in 2 days, actually turned out to be a little higher than I would have thought. But I'd rather be a little low and have you get more money. But again, it's going to be a balancing out. So it's like if you get more in the current year, then I would reduce the amount that you anticipate in budget year. Hopefully, if nothing else, you got that it's really complex and difficult for counties to manage this stuff, especially on the MHSA side where it's so volatile.